Okay, so we're going to start the session. Jaime Ponce, president of the North America chapter until today, I guess. Next president of the North America chapter is Samuel Matar here with us. So this is about different aspects, landscape in North America, robotics, GLP-1s, AI, and many more things that we're going to talk about. It's all interesting topics. So the presentations should be hopefully 10 minutes, 12 minutes, and then we'll have time for 3 minutes for questions. Marina already wants to do more than 15 minutes, but I'm not going to let her. So we're going to have a ringer. So we're going to shut you down. So the first presentation is mine, so that's good. So I can start now. So landscape of research. This is just an overall introduction of everything that is happening in North America. In many ways, don't have any conflict of interest related to this presentation. And so landscape in North America is interesting. 2022, actually, we grew the number of cases. We thought that, wow, we're still doing great. 280,000 cases, 6.5% growth from 2021, recovered from COVID downturn. And it's still in North America, the sleeve has replaced the bypass and the band, and still the sleeve is the most common procedure. So there's no question that this is happening. And when I say North America, United States, Canada is a little bit different, but 65% sleeves. In United States, we have also adopted a new designation for metabolic and bariatric surgeons. This is given by the American Board of Surgery, and it's a collaboration with the ASMBS. And now we get a diploma like this that says metabolic and bariatric surgery, focused practice designation, and we can add those letters to our name. So if you see some of us having those letters, that's what it means, diplomat of the American Board of Surgery, focused practice designation, and metabolic and bariatric surgery. Too many letters, but that's what they want us to put there. But we have now 247 diplomats actually passing the test, and we're keep growing on that number. This is amazing. This is the first time the American Board of Surgery, which is the house of surgery in the country, is recognizing now our field as one of the different fields, independent fields of practice in surgery. And I think the value that we've seen in our own specialty is that it gives validation to the metabolic and bariatric surgery field. We've been seeking this recognition for a long time for all the accomplishments that we have done over more than 20 years. And it helps to differentiate us from general surgeons that are dabbling occasionally in bariatric surgery. And it has helped. It could help in negotiations, cost schedules, compensation, reimbursement. So the other thing that happened in 2022 is we got the new guidelines from IFSO, and everybody's aware of that. And I'm not going to rehearse all those guidelines. But these new guidelines, actually, I didn't think that they were going to create a lot of traction. But there was a lot of PR in the news in the United States. We got the whole SMBS. We have state chapters on every state in the country, so we have 50 states there, and a big access to care committee. And then we have state representatives and industry representatives. And letters were sent to all the medical directors to make them aware of the new guidelines, explain them how our present guidelines, the NIH guidelines, were already 30 years old, and then we have shown that with new evidence, IFSO and ASMBS have published new guidelines that are going to be replacing the old ones, and asking them to really embrace this. So thanks to that, and this was signed by the leadership of both ASMBS and IFSO, we got a lot of traction on these guidelines. And so over the last 2 years, we have been adopted. Now we have 95 million lives covered for these guidelines. I live in Tennessee, so in my state now I can do age of 13 patients, BMI of 35 without comorbidities, and BMIs of 30 to 35 with actually, literally they say that only with severe sleep apnea or metabolic disease, so it's pretty amazing. And when you look at the population insurance coverage in the United States, it's about 70% of the people in the United States have coverage of bariatric surgery, but only 25% have coverage for obesity medical management. And I'm going to skip that because it's, but the awareness of the guidelines is not, it's only us knowing about the guidelines. So then we still need to do a lot more work to spread that, because this is something that was published last year. It was presented in the annual meeting at MBS. It's a survey that was done, and 95% of the primary care physicians, residents, and nurse practitioners were not aware of the guidelines. And very few correctly identify weight loss from metabolic and bariatric surgery. Half of them were aware of the high remission rate, but even with all that, 72% reported that they need more education on these guidelines. So moving from 2022 to 2023, we start seeing this news in the media. This is a news that was published in July 21st, 2023, bariatric surgeries shrink. And so it start getting as a phenomenon that even the industry as well as surgeons start seeing in some of their practices, the case volume dropping some. We may have a drop of, 15-25%. The full numbers, we still don't have them available. Just the MBSA QIP, which is our accreditation, takes time to get the numbers validated, completed and validated. And it looks to me like most of the surgeons blame on the GLP-1s. There could be a little bit of inflation factor, but the media and the GLP-1s have been very strong. You can see Weight Watchers actually included the GLP-1s into their armamentarium of programs, because if not, they would have been nothing. Oprah Winfrey got a show and started saying that she not only resigned Weight Watchers, and as a disclaimer, she said that she was using the GLP-1 drugs and she lost a lot of weight. Again, we wish she would have had surgery, but they created a lot of traction. And I have shown that earlier today in another session, Twitter, that I did among my colleagues. And I asked my colleagues if they felt that their volume have dropped thanks to the GLP-1s. And I got about 46% of my colleagues stating that they did. Now, I don't have as many followers as Neil Flock. Neil Flock has a lot of followers. And so, he called me and said, I'm going to do the same survey, a little bit modified. So he got 57% of his followers, also ASMBS colleagues, saying that their volume has dropped. And this drop is even though there is a lot of barriers in our country for medications. Medications went through a lot of accessibility issues, cost, insurance, production constraints, and long-term adherence. And we know that if those patients, stop taking the drug by the clinical trials, they regain the weight. And we know that these drugs also have a bell-shaped curve. It's only 50% of the patients on semaglutide will lose 15% of total body weight loss. So what happened with the other 50%? So it's less weight loss. But then the other thing is that when you look at the other drugs, tirzepatide, they're also the same thing. They regain weight when they stop the drugs. When they continue to take the drug, they may end up losing a little bit more weight. But real world data, this is an article published more recently, July this year in JAMA Internal Medicine, which is great. Real world data actually shows less weight loss on both medications. You can see that the total weight loss on non-diabetic obese patients is 10% with semaglutide and is 17% with tirzepatide. So that's less than what the clinical trial shows. So the real world data is not the same as clinical trial data. And then you start seeing in the United States this breaking news from companies that have a lot of money, 20% reduction on cardiovascular risk. And amazingly enough, the weight loss on that trial was a trial that shows less than 10% total body weight loss with semaglutide, so 9.4. The only reason that I could identify that may have contributed to less weight loss than the clinical trial for obesity only is that the average age was 61 years of age, which is the risk factor that they get with this for cardiovascular. But then, again, tirzepatide coming up with 38% decrease on heart failure. So surgery actually is not less effective, actually it's more effective. If you look at Aliyah Minian and the Cleveland Clinic paper, which evaluated cardiovascular risk reduction, even follow up at several years 41% risk of death, mortality reduction, 62% reduction of heart failure, and so on. So it's still more effective than any of the two drugs data on heart failure. Tirzepatide starts showing data on sleep apnea. Again, they're going to start continue to add in all these indications. Tirzepatide on liver fibrosis, again, 62% reduction. So the goal here is just to keep embracing and protecting the field. And what message that I sent every time that I have an opportunity is to my colleagues is to keep embracing not only bariatric surgery, but keep embracing the care of obesity care in total, include obesity medicine and your management, because we wanted to have control of that aspect. If we do not have control on that, then we let somebody else control the pipeline, it's going to happen like cardiac surgery. You know, cardiologists will do all the stents and they will send the more difficult cases only to cardiac surgeons. So we wanted to control the pipeline. We wanted to educate patients. We wanted to educate them on what's the best therapy for them or not. And I'm just showing to you that in cardiac surgery, the number of spots of fellowships when the cardiac stents came in, they had to be reduced 40% in order to balance the number of trainees. Shanu Kothari is going to touch on this, and I'm going to skip on this fellowship trends so I can let him discuss more of that. But the other thing that has happened in the United States is the robotic trends. And this is something that we're going to touch on AI and some other things, but robotic surgery has become very prevalent now more over the last few years. You know, if you look back in 2015, it was less than 6% of the bariatric cases being done robotically. You look there, most of the cases, amazingly enough, were sleeves, which you would expect that the people were using more robotic cases on more complicated cases. 2018, it grew up to close to 10%. So in about 4 years, we doubled the number. But then if you look at data from the company, industry numbers, 6% in 2017, 17%, and then grow up to 27% in 2021. Well, the latest MBS IQIP data, we had 30% of the cases being robotic. And I do think, and this is 2022, I think in 2023, the number will be probably more closer to 40% if you start looking at that. So another thing that is happening, is we are using more anti-obesity medications in combination with surgery. I mean, I think that's important. Revisional trends have switched from bands to something else, to sleeve to something else. And so a seamless sleeve to bypass is the most common procedure, and that's what we're going to be focusing on that now. I'm going to skip on that quickly. What I want to show you is that there are different algorithms that I think are clever right now that we are going to start using. This came from a Ricardo Cohen publication that he did, and it's very clever. You know, if you have a patient with a BMI of 50, you may want to intervene early with medications. If you have a patient that is not responding or have less than 20% weight loss, you may want to intervene. And even if you start seeing problems with their adaptability to that therapy. Some patients may have a surgical complications. You intervene and they still struggle. You may still can use the medication. So this is going to be the future of our management, and this is what we're seeing already now. I'm going to stop here, and I'm not going to show you all these slides because I run out of time. And I'm trying to stay on time. But in summary, you know, the IFSO guidelines, world adoption is needed. GLP-1s are eroding the numbers. GLP-1s are still there. Combination therapy is still the future. So I'm going to stop here and let me have an opportunity to answer any questions. Thank you.
Thank you. Before we ask any questions, I just wanted to thank you for your valuable contributions and effort in making the FPD a reality. Appreciate that. It's something we've been wanting for many years. Any questions for Dr. Ponce? Yes, sir.
Curious, Jaime, thank you for that presentation. What has it done to your personal practice? What have you noticed currently in the last 18 months to 2 years? Are you up, are you down, or you're the same in volume, personally?
I am down. I am down about 25%. We had a very strong obesity medicine program, and this has created a distraction.
Pierre?
Yeah, I mean, do you think it's only a gap? Because actually, the new kid on the block is the medication, and after a few years, those patients are going to come back for asking better treatment, or?
Yeah, I mean, the similar question I got asked in another session. So I think what's going to happen is, yes, it's going to continue to contract the specialty some because there's going to continue to be a distractor. But I think at the end of the day, it's going to bring more patients for us. Mm-hmm. And even though the portion of surgery is going to be less percentage, but the volume is going to be more out of that big pie. And so we're going to be able to do still surgeries. And I do think still it's important for us to control that flow of patients so we can, doesn't matter if I grew like 400% my obesity medicine with the GLP-1s, 400%. And I reduced 25% my surgeries. But I do think that if we keep bringing more patients, eventually some of those patients are going to translate into surgery. But it is a distractor. It's a reality. People don't necessarily want something more invasive. They want something less invasive.
Absolutely. And Dr. Kurian's probably going to bring this up when she speaks. But, as directors of bariatric programs, we are equipped, we have the resources to comprehensively treat these patients, whereas the people prescribing these medicines, all they do is just prescribe them, and then they realize that patients are losing a lot of muscle mass, or they don't know how to advise them. So I think there's an opportunity here. I wondered what your thoughts were in us reaching out to these physicians who are writing these prescriptions and telling them, send us your patients. We can help support them.
I have done that. I have gone and visited all these physicians, and they say, I don't want to write the prescriptions. I will be happy to send you those patients. But these patients are very aggressive. They told me, I just want the prescription. I don't want to go to a clinic in which they do a lot of stuff to me and dietitian and all the stuff. After I educate the physicians how important it is, the management of the medications, how many we end up seeing them with vomiting because they're mismanaged stuff, they start pushing it more. But the patients are very aggressive. They want the drug, and if they don't get it with them, they're going to go with somebody else and get it. It's the same thing as if they want to sleep and they don't get it with a surgeon, they go with another surgeon and get it. So same mentality, they're addicted to this concept of an easy path of weight loss. I'm going to stop here, and I'm going to let the next speaker, which is a good friend of mine from many years, Shanu Kotari. Have to thank you, Shanu, for all your leadership and your friendship. And since I was president of the SMBS, he helped me a lot on the clinical issues committee, became president of the SMBS, and he's now president of the fellowship council. And that's why he asked me to talk about what's going on with the fellows in bariatric surgery. That's a tough question.
Tough question. Yeah, thank you, Dr. Ponce, for the invitation to speak. I also want to thank you for already giving my talk, so I'll just answer any questions if there's any in the interest of time. No, I'm kidding. All right, in terms of, these are my disclosures, really shouldn't have anything to do specifically with this talk. I'm going to start with something that caught a lot of attention in the United States, in a state called Oklahoma, which is in the central United States, and that was where the entire Department of Bariatric Surgery, the nutritionists, the psychologists, the APPs, and the surgeons were all terminated by the C-suite, saying there's no future for surgery, it's all medications. Perhaps that was a little premature, but tragically, when you think about not only the employed folks' lives that were impacted by this, but obviously the downstream, all of the patients, potential patients now that were enrolled that are no longer in that metabolic bariatric program. And I thought her quote was very insightful, that they think there's no future because medication will replace what we do. And so other things, we've seen Becker's reports such as this that say they're going to see a 15% decline in inpatient bariatric surgeries over the next 10 years. Now, if you look at the fine print, part of this is also not just the potential for the GLP-1s, but it's also because we're going to, in the U.S., we're being against our judgment, being forced to do our surgeries as what we determine as outpatient rather than inpatient. So it's not like we're not going to be able to doing less surgeries per se. We're going to be doing less surgeries in the inpatient setting, which has more to do with reimbursement than anything else. But nevertheless, that's trending as well. This has caught the attention, obviously, of a variety of people. You're seeing 20 to 30% down, much like, unfortunately, our past president, Dr. Ponce, is noticing currently in his practice as well. In terms of more locally, here in Australia, single-payer system, the advantages, there's advantages and disadvantages to every health system. We know that. No one is perfect, particularly when we get to talk to one another at breaks like this in terms of the health systems we work at in our respective countries. One of the advantages, though, that you have here in Australia of the single-payer system is the ability to track all of your data. This is an elegant 80-page report on the state of metabolic and bariatric surgery here in Australia. And we can see what's going on locally here. You can see the dip in 2022. Now, that was presumably perhaps maybe COVID related. The question, though, is will this trend continue to decrease in Australia, and for how long before we are all thinking we're going to see that potential rise again on the patients that are tired of medication fatigue? When you look at the job board, unfortunately, our own ASMBS job board, I went through that recently, and we only had 3 jobs on there for bariatric surgeons, but there were a lot of jobs available for bariatricians, nurse practitioners, psychologists, all of our integrated health support staff, and medical weight loss specialists. There was a lot of jobs available, but only 3 surgical jobs currently posted on our own website. Sages had 2 bariatric surgery jobs available when I last checked that as well. This was a report, Jaime just briefly mentioned it, but it was done by members of ASMBS and but it was ultimately not, this paper was not endorsed by ASMBS because of the low response rate. It was only around, if I remember, like 8%. And so it's hard to, draw strong conclusions from a paper with an 8% response rate. But nevertheless, when you looked at the bariatric case volume, an interesting question on what's your ideal case volume versus what you were actually doing. You could see the surgeons who didn't want to do a lot of bariatrics in their practice were doing a lot more than they wanted for some reason. But the ones that wanted to do a lot more bariatrics were doing a lot less case volume than they had hoped for in those particular jobs as well. With regards to job satisfaction, when you look at the fellows who graduated in the 08 to 16 era versus more recently coming into the COVID era, you can see statistically there was a difference with the earlier graduates having a higher percentage of job satisfaction and their case volume than more recent grads, which again, is that a function of what's going on in the country, or is that a function that they're early in their practice and they're still building their practices to some extent? Obviously, this has caught the attention that paper caught the attention of Bariatric Times, and interview with one of the authors, Kanur Jane Spangler. And, at the end of the day, her conclusion was, they're still gravitating towards the fellowships in bariatric surgery, they're satisfied, but not as satisfied as they'd like with their current positions. Now, if I switch gears and put on my president of the Fellowship Council hat, because that's one of the questions I get posed. I get texts, I get emails. I think, Jaime, you even sent me a text saying we're training too many fellows, and you make it sound like I am single-handedly responsible for that in the country, which I am not. But you'll see my conclusion after our recent board retreat on that here. But if you look at the number of Fellowship Council designations, you can see that the way the Fellowship Council works is in the United States is it's a la carte, meaning if your program meets all of the criteria for any one type of designation, you can be granted that designation, okay? ASMBS oversees the bariatric fellowships in the terms of requirements for meeting said certificate. So the Fellowship Council, I'm only in the accreditation business. We accredit programs. The sponsoring societies, in this case ASMBS, is in the certification business. ASMBS certifies the fellows on the education committee. So you're setting the criteria for what you think is a qualified bariatric surgeon in the country. Our job at the Fellowship Council is when we go site, for instance, and do accreditation, is just to say, are you following the ASMBS criteria, yes or no? And so some programs have more than one designation because you can meet the advanced GI-MIS, which is overseen by SAGES. You could be, foregut one, which actually is done by several societies. HPB, HPBA oversees the Surg-Onc and the HPB fellowships, things of that nature. So when you look at the total number of them, because obviously some people have more than one fellow in their program, this is where we come up with our over 200 slots in the country this past year going into the match. So let's compare last year's match statistics to this most recent year match statistics. Now remember, they match as a PGY4, so it's still going to be 18 months or more before they start their program. But overall, the take-home message is, we had 99% match rate last year, a 92% match rate this year. We're still having more fellows apply than we have slots available. So it's still very competitive. You still have 100 more people applying for these fellowships that don't get them for whatever reason. Now, so you could look at that and say, yes, they're very coveted. They're not going unfilled like some of the specialties that are only 50% filling that, as long as you apply, you're probably going to get one. We're still very competitive. The only reason we saw the dip this year was really on our international medical graduates. For some reason, that was less this year compared to last year. And whether those are visa challenges and things of that nature, it's hard to say. So back to the ASMBS certification. Last year, there was 101 approved certifications. This more recent year, there was 94 that were certified by the ASMBS. So again, Ben, clap. Obviously, we talked about the numbers. Those were shared with you. We know that, we've seen a little bit of rise in the bypass, little drop in the sleeve in terms of our numbers. But if I just do the math, thank you, Christy, for sharing with me that we have roughly 2,500 members. So if I just did the math on the 280,000 procedures being done in the United States every year divided by the 2,500 members, that comes out to 112 cases per surgeon. And then Jaime yells at me and says, we're training too many fellows, so we just put 100 more into the pool. And now that only changes that to 107 cases, per surgeon on average. Now you could argue that some people are higher volume, some are lower volume, but in general, should we be looking at a steady state versus adding? I don't know what the retirement within our society is. I don't think we're retiring off 100 surgeons every year that do metabolic bariatric surgery as a significant component of their practice. I wish we would have that information to know what is the sweet spot. But we're going to turn that around and make the sponsoring societies decide that. So instead of making it my problem, I'm going to make it Dr. Ann Rogers. We just had the Fellowship Council retreat, and the answer is, like I said, we're in the accreditation business. You guys are in the certification business. ASMBS, if they want to raise the bar, raise the bar. Right now you say 50 anastomotic cases. If you raise that to 75, the number of people who would qualify for that certificate would drop significantly. Now, should it drop? I don't know, but you guys are the content experts. we're just doing the accreditation of what you guys tell us. So we're turning that around, and we're not just picking on ASMBS. We're going to do that for HPBA and every society, because believe it or not, HPBA thinks they're training too many liver surgeons in our country, in the United States, every year. And they have raised the bar, and a lot of them aren't going to have fellowships that are going to qualify in the U.S. anymore. So that's and good for them, if that's the direction they think they should be going. We talked about the guidelines, which I had the privilege of being part of as well. And my thanks to our colleagues at Medtronic, who took our updated guidelines and then used this paper as well from Dr. Arterburn and colleagues. And what they did is, again, this is just on our new qualifications. And this isn't getting into bridge to therapies for the hip, the ventral hernia, the transplant patient population. Just looking at this, we now have 49 million Americans who now qualify for metabolic bariatric surgery compared to 20 million. And so, we have made that funnel significantly bigger. Now, are we going after the health plans? Absolutely. No question we're tackling them, but one by one we're seeing many of them come into a line and either adopt all or a significant portion of our new guidelines in the United States. So that funnel is getting bigger, and even if we're at 1% of the eligible population, although I was a senior author, we're probably down to 0.5% now, I guess. So we're actually doing less, but I mean, percentage-wise, but that funnel has gotten a lot bigger in terms of eligible population now moving forward. So what that is are there no jobs? Or is it that they're in jobs in locations that fellows don't want to practice in? And are they just not willing to do general surgery call? I mean, I did it for 20 years until my most recent job. I did general surgery call. I can still do hemorrhoid surgery. I can still, take out a spleen. I can still take out a colon. I can do all of those things and practice designate expertise in metabolic and bariatric surgery. To what extent will the FPD exam impact that? And again, should ASMBS raise the bar? Again, I think that's a point for you to debate. So at the end of the day, are the bariatric fellows finding jobs? The answer is yes, but. Thank you very much.
So this is awesome. So you're totally right. The 280,000 cases divided by 2,500 surgeons is, how much do you say?
112.
112.
112.
But 280,000 cases, a drop of 25% is a drop of 70,000 cases. And Frank is behind you, so the industry is seeing that number drop. So now we have 210,000 cases divided by the same number of surgeons. That comes to 84 cases per surgeon. So you're right. They will have to start doing something else. They cannot survive only with bariatric surgery. Or practices may stop hiring new fellows because they cannot get to that part. So now that we have here the leadership of the ASMBS and the leadership of the Fellowship Council, and he's clarifying that he doesn't have any authority to constrain the numbers. So he's just certifying the program. So Marina, which is the past president, and Rogers, which is the president, can you go to the microphone and tell us what can the ASMBS has been discussed about this? Are the fellows, because it's evident that the fellows are not finding jobs. I mean, that's not nothing that we can hide.
First, thank you. This is entirely the Fellowship Council. You just let 3 or 4 new programs in this past year for bariatrics because they asked you. So you did hire put new fellowships up there. I asked for these numbers and I haven't broadcast it because I don't think it's probably appropriate, but probably about 23% of our members do less than 25 cases a year. So what means a bariatric surgeon? If you look at worldwide and the number of surgeries that are being done all over, all of our chapters, they are also going to have surgeons that are doing 25 or less, but still are members of ASMBS, et cetera, right? And I think what we're doing right now with all these fellows, because the job market is so low, is that we are training really excellent acute care surgeons that can do minimally invasive surgery, and of course robotics, because we're doing a terrible job training people to do laparoscopy. Not you, Ann.
I'm doing 0 job.
Well, Dr.
So I have no question, just comments.
I know your serve was very strong, but I was very easily able to lob it back to your side of the court. which is, yes, the membership committee, which I chaired last year, did we approve 14 new programs into the Fellowship Council out of the 15? Yes. Was not all of them, but the majority of them Bariatric focused? Yes. This past year did 10, this current year, 10 more have applied. Most, again, have a Bariatric component to it. But my answer is, ASMBS set the criteria. As long as they meet the criteria, they're going to become a member of the Fellowship Council. If they show their volume and their data and their educational component, they're in. So if you just raise the bar, they won't be in.
So, okay, hold on a second. Stop.
That's not the point,
Stop.
though.
Hold on. So I think facts, number of fellows that cannot find a job are increasing. Facts, the volume is dropping. In facts, I think we're doing a disservice, even though we are training these surgeons for a high level of skills. We're doing a disservice for them because we're training for a promise that they can do bariatric surgery, and there's not in the field. So if we don't control this, we're going to devaluate our field and our specialty. I'm going to give a chance to Phil Shower to ask a question, and then Summer.
I was just going to say that if you're telling the fellows that they're not going to get a bariatric job, or it's a very low likelihood, like maybe the Fellowship Council should be publishing the percentage of hepatobiliary and bariatric jobs that the fellows are actually getting, and then that would be like truth in, it'd be truth in advertising, I guess.
That's it. So, in all your presentation, which was great, I didn't see real raw numbers about what percentage of those who finish a bariatric fellowship are getting a job or not getting a job. Do you have that data? You showed there's only 3 jobs posted here and there, but what is the success or failure rate? Who's getting a job? And my fellows, and it's a small sample size, they're doing pretty well the last couple of years getting jobs. But
that's a biased example because your fellows have a lot of contacts, but in general.
No, but instead of being speculating, we're speculating. What is it? Are 10% not getting jobs? Is it 20%? I mean, what is that number?
Yeah. I think in the interest of time, we're going to have to move on.
No.
But
I want the answer.
Phil, Shower, there is an answer for that number. Go ahead.
Yeah, but the answer is, the question is, is it their ideal job versus how many are unemployed? Are they sitting out there with a sign that says,
number of fellows that cannot find a job in bariatric surgery?
Are you guys tracking it? Does the Fellowship Council track, where are these people going?
No,
because my guess is
we don't get federal funding like CMS where they control the market. We're just in the accreditation
it'd be nice
business.
if we knew the answer because we're speculating.
Well, yes, full disclosure, did I have a fellow within the last month of his fellowship still looking for a job? Absolutely.
First of all, we do survey all graduating fellows, so we have an idea of how many of them do land bariatric jobs, and I don't have the number right on my hand, but it's way over 80%. Second of all, yes. Second of all, I disagree that we are doing them a disservice if they're not finding, without a promise of finding a job. It's not our business to promise them jobs. Our business is to train them. We're all here. The majority of us are training. And the future is clear that we're going to be treating bigger, sicker, heavier patients, and which means that they are at higher surgical risk, whether robotic or laparoscopic. So it's even more important to train them appropriately. And I forgot my last point. But
and the answer, last point is if the guidelines really get truly adopted, we're not training enough.
Absolutely.
Rich, you're going to be the last question, and I'm sorry that we're taking time on the other speakers, so we'll let Marina only speak for 2 minutes.
I was just going to say, I think the thing about it is they may have a misperception of what that job looks like. They have this idea that they're going to come out and get this enormous paycheck, and then they're going to get to do 100% bariatrics. And the truth of the matter is, young surgeons coming out of fellowship should be exposed to some general surgery. If I wasn't doing foregut in my practice with this 20% drop, that would have hurt. But I didn't see a drop in my case volumes because foregut filled in the gap. So these surgeons coming out should be seeing a little bit more, they should see a little bit more of the different case volumes. And maybe then as this moves forward, there'll be 100% bariatrics. But, I know Ann Rogers is 100% bariatrics. We had this conversation, but the reality is most practices aren't 100%. I think that's a fewer and far between. If we were to look at the overall, I think that would be surprising that 100% of bariatrics are being done at most programs. So,
Marina, thank you very much.
thank you.
Sorry to put you on the spot. Now we're going to put Marina on the spot, don't worry.
You want to introduce her?
So Marina Curian is our immediate past president of the SMBS.
First has been, guys. First has been.
And now she's becoming the incoming vice president of the North America chapter of IFSO. So congratulations, Marina.
Thank you.
And she's going to talk to us again about how the GLP-1s
Okay.
are being used.
This was actually a topic. These are my disclosures. I do speak for Novo and Vivus, but I'm not going to be really talking about that. Probably they won't like my talk, actually. And just wanted to put this up. We all know what's going on with obesity. These are just numbers, 41.9%. By 2035, it's going to be 58% that have obesity. And there's just, I'm going fast because you don't really need all these, but bottom bullet there, 39 million children under the age of 5 in 2020 were overweight or obese. So we have a big problem, no pun intended, ahead of us. And what we're going to see is, how do we get there? Is it going to be, how are we going to get the most in terms of obesity-associated health condition improvement? Is it going to be bariatric surgery or AOMs? We had the guidelines that updated, as you know here. We have changed it to BMI 35 without comorbid conditions, 30 to 35 with comorbidity, and then obviously in the Asian population we changed in. So this has actually changed. What we're always saying that, we're up around like 1.4%. No, because these guidelines just changed it to like 0.7%. We operate on 0.7% of people who qualify. I want to talk a little bit, first of all, there's already data about low BMI, and IFSO has actually basically said also that, it's not lighting, but anyway, in class 1 obesity, you should be considering it depending on the comorbidity burden, and that surgery would be appropriate in these lower BMIs. And this is also from the Diabetes Organization, saying that in class 1 obesity and type 2 diabetes, it's appropriate to treat patients with metabolic surgery. It's international, UK guidelines also say that. So the low BMI position statement came out well before our new guidelines, and it was 12 RCTs and meta-analyses that they looked at. I'm not going to go through this because it's not important, the pertinent things. So I'm glad Phil's here. Looking at the BMI in patients who had medication versus, they had medications versus surgery. And the surgery are the triangles, and you could see how there's a significant improvement in their and change in their original BMI. So the low BMI position statement basically said 30 to 35 with comorbidities would benefit from this, and it should be considered after a failure of non-surgical. And at the time, they thought that in this age group of 18 to 65, it was really the best evidence for doing metabolic and bariatric surgery in class 1 obesity. And our new clinical guidelines are also coming out with a level of evidence that is incorporated. But I think it's important when we talk about incretins to look at cost. And one of this, and I had gotten into it a little in another session, is talking about the quality adjusted life per year. And many of the people who look and evaluate healthcare costs look at a threshold for the US of 100,000 actually, not 150,000. And SGLT2s and GLP-1s are actually going to be much higher than that. And I'll show you here. So SGLT2s were estimated to be 478,000 per quality adjusted life year versus metformin, and GLP-1s were over $1 million. So these are real non-starters when you're looking at healthcare cost. And current guidelines also recommend that it should be GLP-1s or SGLT2s as first line, but it has to be, if there's cost is a major issue, then it shouldn't be, then they can't do it. So even though, the AHA is going to open up an obesity section, the ADA just did open up an obesity section, this cost issue is going to be very impactful. So this is just some daily news. Hey, sky high cost is going to deter the first line use of these GLP-1s, and also the only way to use these, okay, is if you, let me go back. You'd have to get the cost of the GLP-1 down to $6 per day for it to be a good quality adjusted life year equivalent, less than 150,000, not 100,000, which is actually what most people use. What about bypass? And so bypass actually over 5 and 10 years, I'm going to just tell you what all this says, a lot of words, is that there is a cost effectiveness ratio. And if you look at the cost, it's 28,000 per quality adjusted life year. So this is a good intervention, right? And this is I'm going to click through. This is just showing something similar with euros and in Germany. Obviously, everywhere else in the world, healthcare costs are not as expensive as they are in the US. And then I put this up here because even for surgery in a type 2 diabetes patients who has usually a greater and more significant healthcare burden, it's still proved to be the preferred treatment strategy in this group of patients. Well, so what's happening on the medical side, right? This paper, is it time to replace the bariatric surgery with the GLP-1? And this is just some of the meds that are out there. And, I had thought that there was only going to be about 10 to 15, and someone else said 17, but Nasreen from Saudi Arabia just told me that it's over 100 that are in the pipeline, new meds that are going to come out. And I know that over the past weekend, I was at a consensus and we talked about how Boehringer has a drug that's going to get 35 to 40% total body weight loss. Anyway, in this assessment, again, semaglutide came out over 1 million, but phentermine topiramate, which are other medications, also was significantly lower and is something that you could use in these in patients. This study was for adolescents. And if you did surgery, though, in the early stages, it was too much per quality adjusted life year. But when you hold these out for longer, if you look at 5 years in the second bullet there, you'll see that cost effectiveness comes down to under 100,000. So even in adolescents, surgery even is something that should be considered. And based on our new guidelines, something that we would offer. But surgery does a lot of stuff other than that, right? We treat MASH now with this, and it also was cost effective in treatment of MASH. Now, I'm going to show you some other slides in a little bit, talking about what all the GLP-1s can do for all the health-associated, obesity-related health conditions. But for this part, it did also show a benefit. And historically, bariatric surgery was really the best thing possible for, what? It said 12 minutes.
Yeah, but then.
Oh, shoot. Okay, let me go. Let's skip these. That's fine. Okay, Chanel actually made mention of this. The other way to decrease costs for surgery versus medication is to actually do these things outpatient. And this was an analysis done in Europe, but it's also true for us. And, even triaging some of our patients when they have to be readmitted, for nausea, vomiting, et cetera, it would be saving them money, which would also decrease the cost of surgery versus the medication. So this is what I wanted to show you. Lipid lowering effect of GIP with GLP-1. This is the effect on NASH-related biomarkers that actually significantly decreased with tirzepatide. It also changed visceral adipose tissue, which is really important, I think, to reduce the effects of metabolic syndrome. And then retatrutide came out, is still in trial, but it's 24% total body weight loss at 1 year. So this is the thing that we're looking at. In stage 1 and stage 2 obesity, 20% reduction if you use semaglutide for MACE, right? But surgery does it 40% reduction. And I think when we look at what are we going to offer patients, the cost savings of AOMs is absolutely not there. There is benefit in surgery, but it's going to be winning the hearts and minds of the people. Compounding is happening in our country. It's terrible. I mean, there have been deaths related to the compounding medications. All of these drugs are under patent. Semaglutide, or Wegovy is under patent until 2036. So whatever drug they're getting compounded is not the actual molecule. So And this just, you didn't need to see this. This is what the drugs do, the percentage total body weight loss. This is just the cost of them. And I think when we talk about stage 1 and stage 2, if you have money, then yeah, if you have, you could spend $1,000 a month, then perhaps you can treat it. But this is just showing you that 2 out of 3 people stop GLP-1s by 1 year. So how are they going to stay on them forever, right? So I don't think that this will be the permanent treatment for stage 1 and stage 2. Maybe stage 1, 30 to 35, without any health conditions, you could consider something like this, but maybe something lesser than a GLP-1, more like a phentermine topiramate. And here, this study, just look at the last bullet. Every percentage point increase in out-of-pocket costs resulted in the increased odds of discontinuation. So the cost to the patient, the co-pays or whatever it is going to significantly affect these patients too. And these are some of the things that are out there that are going to be coming out over the next 5 to 10 years. So just to summarize, it's a global crisis. I think you have to look at the treatment depending on the lens in terms of what risk you're willing to accept. But I think if a patient has diabetes and obesity class 1, that I would offer operation and really strongly encourage it over the medics, because we'll have long-term, more durable results. And again, just the cost and availability of all these treatments impact not only how we treat the patient, but what patient options are to improve their own health. Thank you.
Okay, we have time for one question.
I have a question. So we keep talking about how we should embrace AOMs, right? But I'm thinking maybe we should better embrace the people who are prescribing these. So Dr. Kurian, how do you think, because we've got at least 80, maybe 100 drugs coming down the pipeline, right? They're here to stay. So what does the future hold for us embracing this whole concept of AOMs?
I've said this before. We need to do a better job, give metabolic and bariatric surgery like a facelift, right? Or a tummy tuck, whatever you want to, maybe not a tummy tuck. But anyway, why don't we see more patients? Because primary care doctors and even potential patients are like, well, my cousin had this, or, I had a patient have the surgery and they regained their weight. Did they regain all of it? No, but they regained. So there's that perception of MBS being a failure, and we're not. So, we are treating recurrent chronic disease. So adding a medication postoperatively is actually helpful in improving patients' nadir weight, perhaps, or furthering their weight loss. So we need to do it. I understand not doing it pre-op unless you have someone, that's in your division that's doing it for you, medical weight loss, because that will help your numbers overall, I think, for the future. But I think we have to do it. And it decreases the revisions. Honestly, who doesn't want to do a primary case over a revision? If I went from 2 revisions a week to 2 a month.
Oh, good. Thank you.
Thank you. Now we're gonna switch topics. So forget about the GLP-1s now. So robotics and AI, I think is something that we wanted to see on the new technology. So I invited Maria Ilyakova to speak with us. She's used to be a bariatric surgeon in Iowa. Now you're in the global area in New York. Tell us a little bit who you are, and then you can start a presentation. And let's see if we can do this in 10 minutes so we can have time for that.
Hi, guys. My name is Maria. Thank you so much for Dr. Ponce and the IFSO for inviting me to speak. As he mentioned, I was a bariatric surgeon actually at a hospital in Iowa that went bankrupt last year. So these kinds of discussions about finances and economics are not theoretical at all. They really do impact programs. Our program didn't make the hospital go bankrupt, I don't think. We actually made money and had a very thriving program. But, so I'm currently actually still a general and bariatric surgeon. I founded a company that deals with health technology, specifically in staffing and credentialing. So really dealing with some of the topics that we're talking about. Do I use this? Okay, excellent. I do have some disclosures. I do some consulting, and I also have a company. So what do we actually think of when we think of AI, which is the topic that we'll be discussing? I was recently at the Whitney, I live in New York, and they have a biennial exhibit. One of the pieces there was this AI art. AI art can be kind of creepy, kind of weird. A lot of us think the same of AI in general, right? It's a little bit unfamiliar, there's a lot of news about it. Do we really know what AI is? And are we more scared of it than necessarily embracing it? We actually use AI all the time. And I challenge each of you as clinicians and as people in this industry to think of AI as being absolutely all around us. And if you start to think of AI as something that you use in your daily life all the time, you may start to see what kinds of applications we can actually build in surgery and healthcare in general as well. For instance, Amazon, Google Voice, your Alexa, Google Maps, Spotify, any chatbot you've ever used on any service, those are all AI-powered services. In fact, let's talk specifically about what these AI services do well. Amazon does incredible ranking. This is my personal page, and it pulls stuff that I want to buy all the time. Works really well. In terms of your Alexa, it recognizes your voice so well, in fact, that I don't think I've had a failure with that product in the past year or so. The recommendation of routes. In New York, I like to walk a lot, use the subway, I never really drive, and it's spot on essentially all the time. Same thing with predictions on Spotify. You get the song you were really thinking of and really wanted to hear no matter what the day is. And in terms of communication, I will say the bank chatbots and things have a ways to go. So let's talk about some of these AI applications and how we actually use them in medicine and surgery. One you may not really realize is an actually incredibly powerful and great application of AI in surgery and medicine is Dragon, which is the dictation software that probably all of you have used. It is able to recognize your voice and recognize your speech to turn that into text and operative notes for most of us. It's something that's been on the market for about 20 years, and the company was actually acquired by, I believe, Microsoft for several $1 billion several years ago. So really effective company, does really well financially, and is something that's ubiquitously used in 70% of hospitals in the US alone. Some other examples here, sorry, these pictures don't look very great, but in pathology and radiology, there's actually a lot of AI being used for detection, recommendation, prediction as adjuncts to physician work. The one on the bottom left I really like because I used to do a lot of proteomic research and protein design, and there's several projects that work with drug design, for instance, in protein shaping and protein modeling that also harness AI very effectively. So let's now talk about types of AI. This is where everyone will fall asleep potentially, but bear with me for a second. So think of AI as something that takes a lot of information, tons and tons of information, different kinds, text, voice, images, lots of different things, into a funnel, and you can either go to the left or right here. If you go to the left, you're going, right, that's left, yes. To the left, you get descriptive AI, which is basically those ranking, prediction, recommendation, all those things that we saw earlier. It's not generating anything new. You're not talking to your dragon and it's creating an image for you out of what you're saying. It's just turning your voice into text. It's descriptive AI. What we're talking about on the left is something a little bit more complex. Not only are we feeding in a lot of information, but we're also creating actual training models. So we're using that information and then training it to give us certain kinds of results. I specifically put a black box around the generative AI portion here because we don't really know how this works. I've actually created neural networks in the past in my former life before medical school, and we really do not understand why these models create some of the outputs they create, which inherently creates some risk and liability that we'll talk about later. But think of self-driving cars with Tesla. Think about ChatGPT. Think about that image that you saw on the very first slide, and even think of some of these applications in radiology, pathology, and so forth. We're actually creating information and data and results that sometimes we cannot necessarily predict or control fully. So in medicine, we do have some challenges that are a little bit unique. The first picture is actually from Epidaurus, which is in Greece, where I was a few years ago. It's where the Hippocratic Oath, I believe, was originated, and there's some tools there from thousands and thousands of years ago that you can see there. Look a little bit like debates, to be honest. But one of the main principles from the Hippocratic Oath is do no harm. When we're talking about tools that generate predictable results, it's easy to do no harm. But when we're talking about generative AI, which sometimes creates unpredictable results, that is a little bit more difficult to guarantee. And that has some implications we'll talk about. We also must have accuracy. Here, this is a demonstrated use of a glide scope for an intubation. You wouldn't put that in a different orifice that's specifically made for a mouth, that's specifically made to enable an accurate intubation. Same thing with AI. It must be accurate in order for it to be used in healthcare. And then the other picture here, that's a picture from a case that I was doing. We've got to have precision devices, right? We have to have targeting and precision for any of these tools that we're using for them to be effective. And then the last is just a HIPAA binder from our program, but there's a lot of risk inherent when we're using any kind of technology in healthcare, right? Da Vinci, Hugo, Ottava, all these have to go through very extensive FDA regulation and approval, monitoring, all of that. Arguably, potentially, so does AI, especially depending on what kind and how it's used. So what should AI do in medicine and what should it not do? This is my personal thoughts, but I think it's also pretty well understood in most industries. It should assist physicians and arguably patients. It should decrease our busy work. It should improve our precision and accuracy. And it should allow us to parse large amounts of information to make it more simple and easier to use. What it shouldn't do is replace physicians. It should not take upon the responsibility of final decision-making or irreversible decisions, and it certainly shouldn't increase risk or work. And that really goes back to those 4 principles that we talked about earlier. Doing no harm, making sure that these tools are accurate and precise, and making sure that we're addressing the risk and liability that these tools inherently have. So what are some current applications of AI specific to bariatric medicine and surgery? SAGES has a safe cholecystectomy program that is also paired with another global AI collaborative that's being led, I believe, by Dr. Amin Madavi. And this is being used to train off of videos that are completed by surgeons in order to annotate certain portions of cases, certain anatomical structures, what tools are being used. And this is also being inherently tracked in the platforms being used, like Da Vinci from Intuitive. So this eventually enables us to be able to recommend, predict, and even automate surgery down the road. BariBuddy is actually a ChatGPT customized program for patients that I created out of trained data, and I'll show you how I did that. And then some other interesting applications that are surgery adjacent, but really important to what we do, are things like insurance claim auditing. So making sure that the documents that we actually submit and how we submit them, insurance companies are way ahead of us on this. We're a little behind from the provider side. They're way ahead. This is how I developed the BariBuddy ChatGPT. Really tiny font, sorry about that. But basically, you crystallize your problem, you define it, you feed in data, you train, use a training model, you test it with users, and then you use it. And you keep doing that over and over again. And you can see on this next slide, these were actually the specific materials and programmatic inclusions that I created for it. I put in evidence-based papers and things like the IFSO guidelines from 2022, for instance. IFSO and ESMBS are MISQUIP accredited program materials as well that had been revised that year, included safety thresholds, excluded certain materials, and limited access to external content. And then I trained it with hundreds of patients, which is another part of the training model. So really being thoughtful about, yet again, your risk, your accuracy, your precision, and what the ultimate purpose of your AI is. So here are just some future applications in bariatric medicine and surgery that I put together. Most of these images are created through AI, but think if we could actually recognize your voice in the OR and be able to auto-dictate a note and what's going on in the case from there. What if we could actually recommend or be able to predict things like the accuracy of our prior authorizations using AI? So lots of food for thought, hopefully, for you. Thank you so much for the opportunity to speak. If anyone's interested in this topic, I'd love to talk with you further. Thank you.
So that's amazing, and I think knowing that all the big companies are buying AI and trying to adapt to that, the applications that I see even in surgery, it's amazing. I mean, you can start predicting a lot of the things that are going to happen in the case. So any questions for Maria? Yes.
Yeah, Chris Hensman, this is a question in general. It specifically addresses robotics. And I'm a robophile, I love the platform, but I'm not convinced yet because there is no data. We're talking about reduced numbers, we're talking about cost, we need to be talking about value proposition. We've got several series. We've just completed our own review of our robotic bariatrics, and let me tell you, the warning signs are there that perhaps we need to rethink how we implement new technology. It will be someone else will point it out to us that perhaps before we really know the value of something, we've adopted it.
Mm-hmm. I think it's a really, really interesting question because we went through a very extensive financial analysis in our own program, even in the hospital that went bankrupt. But I think the really interesting thing to think about is not how we use the technology now, but how we will use the technology in the near future. We will be using robotic platforms to do remote surgery in the future.
Thank you.
And that's not possible to do with open or laparoscopic
Yeah,
surgery.
I accept that. But imagine this, if Boeing come to you tomorrow and say, we've got a new aircraft, but we're going to test it. And some of you may fall when we first implement it. So look at how new drugs are introduced. There's so much scrutiny. But when new technology is adopted, we seem like we've let the ball go.
I completely agree with you on that. I will say that I think actually robotic surgery does go through extensive FDA approval and monitoring and clearances. AI obviously doesn't. So you bring up a really, really good point of what is the cost, both financial and otherwise, and how are we actually considering the value proposition of these tools? Because a lot of AI in healthcare and elsewhere is dumb and shouldn't be on the market and doesn't work very well or causes harm. It's a great question.
How are we going to be able to control AI use by, answering questions, reviewing papers, writing papers, instrument, it's like it can be used for anything now. And how are we going to control that? It's going to be an AI that controls AI use.
Yeah, I mean, it's kind of the same questions that were asked when Google came out, like, oh my God, this is the end of college students writing their own papers because they're just going to use Google and find papers. And now we have ChatGPT to be able to write papers. To be honest with you, I do think the cat's out of the bag in terms of the ubiquity of some of these tools, but there are absolutely ways to build them well and to make sure that they're verified, make sure that the content that they're being trained on and how you're training them is validated. And I would really look to actually the Surgical AI Collaborative through SAGES as an incredibly good model of how to develop useful tools, safe tools, and thinking of intended use. So it can be done.
Is it true that there are digital watermarks that can tell whether some document was AI created or not?
Yes and no. If you guys have heard in the news recently, like Telegram, it's a company that's based out of Russia that does blockchain undetectable kinds of things. There will always be a company that won't trademark and that will be open source. So there's a limit to that. Again, I think the technology is out of the bag. But what we choose to use in certain applications, specifically in surgery and medicine, that we get to choose. So
thank you very much.
Excellent. Thank you. Now, my dear friend and colleague and present president of the SMBS, Ann Rogers, is going to, moving along on the same topic right now, robotics. She's going to tell us that it's here to stay, huh?
You don't buy that?
Just go ahead.
You know I'm right. All right, I have the following potential conflicts, and yes, I am a paid shill for Intuitive, I admit it, but that's because I really believe in the product, and I really do believe it's here to stay. IFSO asked us last year to tell what percentage of operations we were doing, and I am almost 100% robotic, I admit it. This paper came from the participant use file of MBSA-QIP in the 2015 to 2020 years. And at that time, 17% of sleeve gastrectomies were being performed robotically, over 17% of bypasses were, and over 28% of duodenal switches were being performed robotically. And that was in that time period. And then we come to 2022, where fully 30% of bariatric operations were being done robotically and 70% laparoscopically. And you can see those curves are going in one way or another. And yes, this came from Da Vinci, and they do show a crossover in there. Their crossover happened around the year 2023, and I don't think it has quite gotten to that point yet, but I don't think it's far off from reality. So first of all, why should we become totally robotic? A lot of people want to talk about outcomes, and we have to say they are clinically comparable in many, many papers. This is a paper from my friend Wes Fosberg, who showed that robotic sleeve has an equal rate of VTE and organ dysfunction. Bypass actually had a lower rate of infectious complications, lower rate of transfusion, and equal rates of VTE and organ dysfunction. So very, very good. This was a meta-analysis that came out of a group that said that there's absolutely no significant difference in key outcomes between robotic and laparoscopic gastric bypass, and I believe that that's true. Here's another paper that had to do specifically with sleeve, and there were not significant differences between robotic and laparoscopic groups in terms of length of stay, excess weight loss, and complications. Tammy Kendall's group looked at this, and I know that Tammy Kendall is sort of a robot hater, and they were hoping to say that it was more painful to do things robotically, but unfortunately they found that there was no difference in opioid use or pain scores between patients who had laparoscopic versus robotic surgery. This was from my friend Sarah Samri, and she was looking specifically at stapler use. And if you look at the currently available stapler and the currently available platform compared to bedside stapling, there was absolutely no difference in patient outcomes. Okay. This was a paper looking at robotic-assisted versus laparoscopic bariatric procedures in patients with BMI of 50 or greater, and they said that robotic platforms may help surgeons to overcome the technical difficulties in these patients in which you're working in multiple quadrants, and the intraoperative and post-op complication rates and length of stay were absolutely the same. Okay. This paper said that advancement in bariatric surgery, they were comparing laparoscopic and robotic techniques. I won't read the whole thing, but I focused on a couple things. In terms of gastric bypass, no significant differences in terms of length of stay, weight loss, weight regain, or 30-day mortality. The robotic approach showed fewer complications, a shorter hospital stay, reduced need for conversion to open surgery. When they looked at sleeve, there were lower rates of transfusions and bleeding compared to laparoscopy. And in terms of the SADI procedure, the findings showed absolutely comparable results between robotic and laparoscopic techniques. And so robotic technology has proven to be safe and effective, and it is non-inferior. Okay, so that's important. This paper showed outcomes of robotic single anastomosis duodenal-ileal bypass, and they did their own center. It was feasible, it was effective, it was similar to laparoscopic, and they found that the learning curve for this operation was 27 cases, which is really not very much. This came out of Andre Texera's group in Orlando, Florida, and they were looking at their duodenal switch procedures with the Da Vinci Xi platform. They had 661 patients. Their 30-day complication rate was about 9%, but only 1.9% of these were considered major complications. The readmission rate was 6%. Their complication rate between 30 and 90 days was 0.9%, very, very small. Okay, and then we had some abstracts that were shown at our annual meeting in June, and this one came out of Celebration Hospital. It is a totally robotic hospital, and they found that metabolic and bariatric surgery that was performed robotically compared to laparoscopic actually had a shorter length of stay and fewer complications and a shorter time in surgery. So maybe it's not just equivalent, maybe it's actually even better. Okay, there was another abstract shown specifically looking at patients with type 2 diabetes, and again, their outcomes were better with robotic the robotic platform compared to conventional laparoscopy. So now, I'm an old bag, and I'm old enough to have been a lap chole naysayer. You can do an open chole in 20 minutes, skin to skin. Why on hell would you spend 6 hours doing a lap chole? Okay, it was very easy to do, but there was a lot of concern early on about bile duct injuries and what's going to happen, but how quickly did lap chole become the gold standard in what we do? Very, very, very quickly, because it's better. Okay, now, it is hard to demonstrate a difference between laparoscopy and robotic surgery. It was very, very obvious that you could show differences between open surgery and laparoscopic surgery. That was huge. Okay, so we're talking about not different kinds of apples, not apples and oranges. But at this point, if you take surgeons' opinions on laparoscopic versus robotic literature, as far as I can tell, it seems to depend on whether the surgeon is actually using the robot. It's kind of like your belief in God, okay? There's a lot of people who are absolutely certain that there is a God, and then there's some people who are fairly certain, and there are others that are not. The tiniest is, I don't know. Okay, and then yes, I definitely don't, whatever. But the people who do believe in robotics are big, and the people who don't believe in robotics are small. But the issue is the following: if you're looking at robotic surgery, it definitely has improved ergonomics, and there's less fatigue for the surgeons. And I think that's a really, really, really important thing to look at. It's not just what's better for patients, it's what's better for surgeons, because it's going to prolong our surgical lifespans. And, there's more degrees of freedom, and it's easier to do. And now, cost always comes up, and people worry a lot about the cost of robotic surgery compared to laparoscopic surgery. And if you look at just the direct cost, yeah, it costs a lot of money to have a surgical robot and blah, blah, blah. But if you look at overall costs in terms of taking into consideration complications, readmissions, and reoperations, it's actually cheaper, according to this study, to do things robotically compared to laparoscopically. And especially if you're doing things hand-sewn instead of stapled, you're saving a lot of money. So robotics, as Maria Ilyakova was saying, provides this digital interface between the patient and the surgeon, and there's a huge potential for the use of artificial intelligence and machine learning with this. We got fluorescence imaging, we've got image integration, augmented reality, telesurgery, all sorts of platforms that are available when you're using the robot that are not necessarily available when you're working laparoscopically. So this is truly disruptive technology, I understand that, but there's other examples of it that we use today. Mobile phones, okay, ride apps, mobile streaming services, GPS systems. We use them every day. Yes, they're disruptive. We don't take taxis anymore. We call it Uber. We're never going back. And this is true for robotics as well. And so the bottom line is, you may not like robotics. You may not use it for any or all of your cases, but it is definitely here to stay. If you look at what's going on in terms of the use of robots across all kinds of surgery, it's just going up and up and up. It's not going away. It's going up. And if you look at training, MIS fellows training in robotic is definitely growing. And these people, when they come out into practice, are going to be looking for jobs where a robot is available. And this is the increase in use of robots in MIS training. So my bottom line is, it's going to be the preferred technique before 2030. In fact, it may be before that. And I'm sticking to that. Thank you. Happy to take any questions.
Any questions for Anne?
I have a question. Oh, I'm sorry.
No, go ahead.
I've always been amused by this robotic versus laparoscopic comparisons that we've been making over so many years. And the reality is they're both laparoscopic, right? The only difference is that there's a computer between you and the patient.
Yep.
And so I wonder, is this just a gradual transition that we're all going to make and use this device to maybe improve the conduct of the operation, but it's still the same operation.
Yep.
It's still laparoscopic.
Yep, absolutely the same. I suffered a number of orthopedic injuries doing laparoscopic bariatric surgery, and it got to the point that I had to convert in order to be able to continue to operate. And so I have found that I'm actually a better surgeon robotically than I was laparoscopically because I can sit down, calm down, think about what I'm doing, and complete an operation. Shonel?
Yeah, great talk, Ann, as always. Full disclosure, I don't use the robot. I use the robot every day to hang my white coat on before I use these God-given instruments. But
That's a bad use of an expensive coat rack, Shonel.
Yeah, it is very expensive. Do you think it's possible, though, like in most studies show equivalence,
Yeah.
never superiority?
Which they didn't
and
5 years ago.
Right, but I'll give you, like, just make it about the surgeon. There's nothing wrong, like I said, about protecting the quarterback and keeping us in the game longer from the ergonomic standpoint. And if that's what the companies would say, that's fine. I wish that's, as opposed to trying to say it's superior. I wonder about the one study that you said where they actually had better outcomes.
Yeah.
You said it was a fully robotic hospital, so maybe that's the whole point is they can't get in the robot room, so they try to do it straight stick, and they're not very good at it, so therefore their robotic outcomes are actually superior. We're seeing this in fellows that are doing MIS fellowships to learn straight stick because they started out 5 years, their first gallbladder was robotic, which I think is we're doing a disservice in our training when they do that.
Well, and I have to say, I'm losing some of my laparoscopic skills because I do operate robotically almost all the time. But most of that has to do with torque of the abdominal wall, and I don't want to destroy instruments or myself.
But there's a younger generation that's going from robotic straight to open surgery when they're struggling. And that's, you kind of wonder about that.
I don't know what to do about that because I'm not going to go back in time. I'm not going to teach people open gallbladders so they'll know how to do it when they have to do it, right? They're just going to have to figure that out when they're out in
Well, that's what
practice.
the trauma acute care service is for. They'll get plenty.
Yeah, I hope so.
Let's have one more quick question, and then we'll go with the last presentation.
It's interesting. People often use that comparison going from open to laparoscopic
Right.
as the same as lap to robotic, but there's a big difference, Ann, and it's called evidence. And it's called...
I don't believe in that,
and this is not religion, because we have this scientific method that I think we all ascribe to. It's not just belief, it's evidence. And it was very easy to show.
It was a great slide, though.
Let me just finish. It was a great slide. We could easily measure the benefit. Not only was there clinical benefit, actually there was benefit ergonomically too, because the hung over like this, we stand erect. It actually reduced cost. Now you just told us that there's absolutely no clinical benefit, and you didn't share real cost data, but most of the studies, and I mean, I think Tony Petrick's data is probably the most accurate from Geisinger, showing at least $3,000 increase per cost. So there's no clinical benefit. We're adding $3,000 cost to a bariatric procedure. Our colleagues in Mexico are doing these operations at $5,000, and we're in the US adding cost. And then you're telling us that there's an ergonomic benefit that was some review paper, someone's opinion. You can also measure ergonomics. Show us the scientific evidence that these are ergonomically better, as opposed to let's just assuming I feel better. And then finally is, give me that $3,000 and give me a nice massage after the procedure, and give me a cup of coffee and a whiskey, and I'll feel a lot better.
No, me too. No, Adrian Park has a lot of, I didn't have time to go into all of the details, but the most expensive thing is the replacement of surgeons, and it costs about $2 million to replace a surgeon. So that's a lot more than $3,000.
Well, give me evidence that it's going to replace the surgeon, or it's going to prolong this. Give me evidence.
If I die, there will be a job for one of those fellows they were talking about.
Okay, we're gonna stop the questions for a second.
I was just getting started, having fun.
I know. Let's. I would encourage you to stay at least for 5 more minutes after the 5 o'clock, because we're gonna see the potential change on how we do anastomosis here. So, our inventor, Michel Gagnier from Montreal, Canada, is gonna describe to us this magnetic surgery concept.
Thank you. Not going to be very long. This is our multi-institutional study. It involved 4 countries, Belgium, Spain, Georgia, and Canada, in which we did this MAGD, magnetic duodenal ileostomy, which is a side-to-side anastomosis, different than the single anastomosis duodenal switch. In the first generation device, which was a 3-centimeter neodymium magnet encased in titanium, and you can see there's a groove here, and that groove is important because that's where the healing of the anastomosis happens. The center is the necrosis, and the healing happens around. It is transported in front of an endoscope, as opposed to our competitors that have used the magnet in the channel of the endoscope. And this is transported to where you need to make the anastomosis. In the first generation device was not a swallowable magnet at the time. We had to transport it to the ligament of Treitz in order to grasp this magnet in the first centimeters of jejunum with what we call a laparoscopic positioning device, which is essentially another magnet, neodymium magnet covered with titanium, but made laparoscopically with a joint so that you can surf this endoluminal magnet to the right position. And our position was to make it at 250 centimeter, which was similar to the classic duodenal switch, or SADI, from Dr. Torres. And so it is a side-to-side anastomosis, and you can state that this is a step before the full CD, where you could transect the duodenum below this anastomosis. Now, the second magnet would be brought into the duodenum with another gastroscopy, and we would bring this anticolic and then close the mesenteric defect to prevent an internal hernia. So we have published several articles. This is one of them, published in SWORD, and we had 2 cohorts of patients. One that had sleeve plus magnetic anastomosis, just like a CD procedure, on bigger patients. And we had another cohort in which they had the magnet after the sleeve gastrectomy. This group was for weight regain or reappearance of comorbidity or not enough weight loss. And you can see here in blue is the total cohort, but separated are the gold in percentage of total weight loss for the magnet plus sleeve, and in green the magnet after sleeve gastrectomy. You can have it in percentage of excess weight loss. It reaches 86% for sleeve plus magnetic anastomosis. It's, I think, very similar to a full SADI procedure. And the percentage of excess weight loss after sleeve gastrectomy is 27%, but these were also smaller patients. We also had an effect on type 2 diabetes. In this cohort of patients, you can see the drop of glucose was more than 40 milligram per deciliter, and hemoglobin A1C also was from 6.8 to 5.2. We then went to a second generation device, and this is to improve on our result of the first generation device. This device is swallowable, and in order to make it swallowable, we had to make it thinner. We also had to make it less wide. And this is compared to the Allurion balloon. We have it approved in Canada, so we are using the Allurion balloon. I think it's coming in the United States, but just to show how thin it is compared to a swallowable balloon, and also to a pill cam. I wish I had a picture of the pill cam next to the swallowable magnet. So now the magnet is swallowed 2 or 3 hours before the procedure, and an X-ray is confirming where this magnet is located in the jejunum. We sometimes have to use contrast because if the magnet is in the middle of the abdomen, you don't know if it's duodenum or if it's jejunum. But definitively, it fits on the left side, you're in the jejunum. And there is an absorbable membrane, so we've replaced the total titanium to a PGLA, polyglycolic acid, that dissolve in 2 weeks. And we thought that the magnet stayed too long in place in the first generation, and now that disappears in 2 weeks, and the magnet drops on average after 21 days, which is, we obtain a collagen deposition from day 7 to day 21, about 14 days of collagen, which I think is strong enough to avoid a leak when the magnet pass. So in this protocol, we decided to do this in Georgia. The first swallowable magnets were 4 centimeter in length for type 2 diabetes patients, body mass index 30 to 35, so class 1 obesity, and only the magnetic anastomosis. There was no gastric intervention on these patients, so we would study the magnetic anastomosis. We've done 15 cases. These are some of the subset of first 9 patients, 53 years old, 56% female, and type 2 diabetes was 100%. You can see the hemoglobin A1C was 7.8. We've obtained at 6 months a drop of body mass index from 32 to 28. That's kind of modest. And here you can see the numbers. And in percentage of excess weight loss, because remember this is class 1 obesity, it represents a 63% excess weight loss at 6 months. And the glucose went down from 191 to 129, and hemoglobin A1C to 6.4. I know that Phil Schauer had put all those randomized control trials together, and the lowest point that in those studies reached 6.5, if I remember correctly. So at 6.4, we're not too bad at 6 months, and we need to follow, 2/3 of these patients need to be followed to reach 1 year, and beyond probably followed another year because they may get a more effect on type 2 diabetes after a second year. So some of the adverse events have been mostly minor. We have grade 1 and grade 2 Clavien-Dindo in the classification. There was 2 patients that had readmitted with nausea, vomiting, and I think we discovered that these patients are getting the effect of the duodenal ileostomy, kind of a dumping syndrome. So, as I said, I promised I was going to be short, and we have done now a total of 95 patients. We're getting close. Next month, we're going to go over 100 patients with magnetic anastomosis, and we've never had a leak, a bleeding, an obstruction at the anastomosis caused by the magnet. We've had 100% patent anastomosis and passage of those magnets by defecation. We've never had to do an endoscopy to look for these magnets. So I think it's promising. We need to do more patients. We need to do it in more countries and in more new indications. I think it's promising for type 2 diabetes, which might be something that might be more powerful than the drugs that we have right now, GLP-1. And I think it could be more cost effective in the long run rather than taking drugs with the compliance as we know. We're going to have another 3rd symposium in the end of May in Montreal for those of you who are interested with live surgery. Thank you very much.
We're going to take